So much for inviting me. It's been an honor. I've never been here before, and it's simply been a pleasure. I've enjoyed today and being here the last few days. What a place you have. So again, thank you. More specifically, thanks to Josephine Wang, Alice Wang, Mary Sang, who's just set up a wonderful trip, and then Drs. Eric Fong, Wei Zhang, and they've been amazing to invite me here and put on such a great conference. I'm going to talk today about the EdHealth study, the National Longitudinal Study of Adolescent to Adult Health. It's an amazing study that I've had the privilege now of inheriting as director about 4 years ago. And before I get started, I just want to thank all my collaborators on EdHealth, subcontractors and staff members. All told, right now, over 300 people work on the study. And so it truly is a team effort that we're trying to collect wonderful data for the scientific community as a whole. So, and specifically thanks to my predecessor, Kathy Harris, as well as to Allison Aiello and Eric Witzel, who are my main collaborators on the study right now. I have three goals in my talk today. The first is to talk about this data set, and hopefully a few people will use it. So I know some people here do, but especially for students in the audience who may not be aware of EdHealth, hopefully it's something that you'll hear about. Second, maybe it provides a lesson or two as well if anybody wants to collect a data set like this. It's a huge challenge, but it's also fun. I learn a whole lot. And third, I want to keep you awake. It's after lunch, and that's perhaps my greatest challenge. Okay, the overview of my presentation. What I'm going to do is go back to the origins of EdHealth and talk about the background and design. Second, we're in wave 6 right now, the 6th wave of data collection. We're in the field right now. So I'll talk about the goals of wave 6 and the design of wave 6. Third, I'll talk about the data collection to date. I've split up wave 6 into 2 subsamples, sample 1 and sample 2. And then, so I'll talk about why we did that and how we're doing with those 2 subsamples. We also do home exams of our willing participants after the folks take the survey. So I'll talk about the home exam process, other dimensions of EdHealth data collection, including contextual data collection, mortality surveillance, environmental data collection, and so forth. I'll give you a small sampling of some of the unique measures we're collecting in Wave 6 and a little bit of data, albeit it's not complete because we're in the field right now, but it's something to look at. Talk a little bit about how to access the data, and then acknowledgments, especially for the funder. The main funder right now of EdHealth is the National Institute on Aging, which you may know EdHealth comes out of adolescence. Thankfully, adolescents don't stay adolescents forever, and the folks we're following now are in their 40s, and National Institute on Aging has funded a good bit of the study now. Okay, so a little bit on the background and the original sample design. EdHealth was developed over 30 years ago now in response to a congressional mandate in the United States to fund a study on adolescent health. It was in the era of HIV and AIDS. There was very little known about sexual behavior and drug use among adolescents in the United States, and that's where this came from. That was out of the Clinton administration, and when Congress became democratic in 1993. It was originally a 2-wave study, just going to be waves 1 and 2 of middle school and high school students. And then through the innovation of the PIs, it became a longitudinal study in the early 2000s, and it's been ongoing ever since. So we don't add new people to EdHealth. We follow the same cohort as they age across time. It was renamed the National Longitudinal Study of Adolescent to Adult Health in 2014. And in 2016, EdHealth won the Golden Goose Award from the U.S. Congress, which is quite an honor. It's the federally funded research that lays the golden scientific eggs, and both sides of Congress make speeches about this, and it was quite an honor. I have one of these trophies in my office, even though I had nothing to do with it in terms of getting there. The trophy I have is from the founder of EdHealth, Dick Udry, who passed away about a decade ago. Okay, so AdHealth is exceptionally unique compared to many studies of health and aging in the United States, and I would say around the world. We have prospective data since adolescence. We have biomarker data from blood samples, anthropometric data, height, weight, waist measurements, and so forth. We have genomic data on most of the participants. We have cognitive data and we have all these measures before many health outcomes manifest. We have very rich data from multiple levels. So we have cellular data all the way up to contextual data at the county and state levels. So we think of AdHealth as a cells to society kind of data set. We also have parental data. When the folks were in adolescence, there was a parent survey, and another study right now that's run by Kathy Harris and colleagues is collecting another wave of data from the parents. The parents of the AdHealth sample members are around 70 years old right now. The study is very diverse. We have, so it facilitates many analyses of health disparities by race, by ethnicity, by socioeconomic status, by sex and gender, by sexual orientation, and gender identity. And it's nationally representative. So it's multi-level, longitudinal, cells to society data set that has facilitated lots of research over the last 3 decades and will continue to for the foreseeable future. We have restricted data users all over the world. Restricted use means that these are data, all the data from AdHealth through contract. I don't know if you can see it, but there's a contract or two from Hong Kong. I don't know if that's current or not, but there are data users here in Hong Kong. And then in terms of public use downloads, at the ICPSR at the University of Michigan, AdHealth has been the most highly downloaded data set in the world over the last 15 years or so, with over 1 million downloads, many by undergraduate students all over the world. To date, we're nearing 5,000 publications. To date, I get a report every month. It's almost a paper a day that's coming out using AdHealth data these days, all over the scientific map in health and medicine, social sciences, education, criminology, general science, and so forth. And then there's also hundreds of other publications and presentations per year, books, dissertations, chapters, and so forth, conferences. The data set is very well utilized. Okay, I want to talk a little bit about the sample design of AdHealth, which was so incredibly innovative when you think about going back 3 decades ago or so. What the PIs did at the time is collected a list of all high schools in the United States, nearly 27,000 high schools. Small, large, urban, rural, private, public, and so forth. And from those 27,000 high schools, sampled 80 of them. Every kid had a chance to be in AdHealth, and then there was 80 high schools sampled. Those high schools nominated a feeder school, a junior high school or a middle school, and so those there turned out to be 132 schools represented in AdHealth because not every high school had it. So some schools had 7th, 8th, 9th grades. So as it turned out, these 80 high schools, 132 schools in all, kind of were the sampling units of AdHealth. And from there, individuals were sampled in every grade, 7 through 12, to construct the main sample of AdHealth. But beyond the main sample, toward the bottom of the slide, you can also see that there were, in addition, oversamples. So some schools, every individual in those schools were included in the data set. So some schools, we call them saturated schools, where everybody was included. So you can get friendship networks and sexual partners and so forth within those schools. There were racial and ethnic oversamples in AdHealth as well. There was a disabled student oversample, and then there was a genetic oversamples as well. They really tried to get as many twins and sibs, half sibs, and so forth into the data set as well to facilitate analysis of genetic and environmental antecedents of health and health behavior. Okay, so the context and goals and design of Wave 6. So let me go back for just a second and say one other thing. What this design yielded was a sample of 20,745 adolescents. So over 20,000 adolescents in grades 7 through 12 in 1994-95. So they're in their mid-40s now. And we've tried to follow up every single one of them ever since. Okay, so for Wave 6. NICHD was the main funder of AdHealth, National Institute of Child Health and Human Development, over the years. And after Wave 5, they said that's about it. If you want to find funding for AdHealth, you're going to have to go elsewhere because they're kind of aging out of our funding. So my challenge in taking over AdHealth was to find that new funder. And so with help from Kathy Harris and other colleagues, in many meetings with the National Institute on Aging, many trips to NIH, talks and pre-proposals and so forth, eventually NIA put out a call for applications. I applied with my team, and we were successful in getting Wave 6 funded, primarily by the National Institute on Aging. The rationale that my colleagues and I used is that US population health is much worse than other high-income contexts, including Hong Kong, everybody knows that, and many other countries. There's major US midlife health problems and concerns. Obesity rates are around 45% in AdHealth, and that's nationally representative in the age 40s. Physical functioning problems, there's so many people in AdHealth that say they have problems climbing stairs and things like that. There's huge mental health concerns in terms of suicide ideation and lots of drug use, lots of alcohol use and so forth in AdHealth, and higher rates of mortality as well than we've seen in the past couple of decades. There's also major health disparities in midlife in the United States, not only by race and ethnicity, but especially by socioeconomic status, growing disparities by educational attainment, for example. And so there was lots of rationale to fund a study that would help the country as a whole understand health among people in their 40s and the disparities therein. One of the particular things as well that I'll highlight in the middle of the slide as well is cognitive functioning. So the National Institute on Aging has a lot of data on older populations and with big concerns about Alzheimer's disease and related dementias. There's very little nationally representative data on midlife in the United States in terms of cognitive functioning. How is people's memory, short-term memory, and so forth. So one of the things that we're doing, and you'll see in a few moments, in Wave 6 of AdHealth is collecting a lot of cognitive data, both on the web, which has never been done before in terms of nationally representative data in this age range, as well as in person. And so we're going to be able to compare the cognitive data across those two modes as well. So NIA has funded us very generously, and so now we're in the field. Our goal for Wave 6 is simple. We want to collect and disseminate high-quality data on life course determinants and trajectories of health, cognition, health behavior, and health disparities among this large nationally representative cohort aging into midlife. You might notice here that there isn't a data analysis in this. We are funded exclusively to collect data and to disseminate data. It's for the public. It's not for me. There's no hypotheses in here. Of course, I want to use the data. I have my own ideas here. But what we're trying to do as a team is to think about what would the scientific community best benefit from in this data collection effort, and to get that data out to the public for use. Okay, there's a little bit of a busy slide, but this figure depicts the longitudinal design of AdHealth. The wave of data collection from the mid-1990s is in the top row across, and then the present, Wave 6, which I've circled in red there, is the current wave. So the figure shows that if you look in the middle, the survey administration, there's 20,745 participants from Wave 1. And as we go down the middle row, you can see the cohort aging into young adulthood and now into middle adulthood. Our goal in Wave 6 is to collect 13,000 surveys, if you can see right toward the bottom there, in AdHealth, which is a pretty amazing retention if we can hit 13,000 over 30 years. And then we're collecting as well birth and death records, we're collecting parent surveys, and again in a separately funded study, and a lot of biological data as well. And I'll talk about that in a few moments. At the top of the slide, you'll also see as well that in every wave of AdHealth, there's a lot of contextual data being collected. The idea here is no one can understand health and health behavior among individuals without reference to the context that surround them. Think about the schools from wave 1, the kids in bed within their schools, within their families, within their neighborhoods, within their peer groups. And those contexts, of course, change and evolve over time, but we're very much concerned with collecting contextual data in wave 6 as well. Cognitively, as Ad Health, wave 6 of Ad Health is best suited to explore young to middle adulthood. Again, when we think about cognitive data collection, there's a lot of data in older adulthood. Think about the Health and Retirement Survey, for example, that starts most of its cognitive data collection at age 65 and beyond. But with one of the things that we're innovatively trying to do here is to collect a range of cognitive data among people who are in their 40s, so to establish baseline levels, and so that as people age into middle and older adulthood as well, we can best understand cognitive health, cognitive disparities, and how those outcomes are related to things like obesity, drug use, alcohol use, socioeconomic status, and more. Okay, for wave 6, we developed this 2 subsample design. This is a little bit busy, but let me talk through a little bit because this is really important for what we're doing in wave 6 of Ad Health. On the left side is sample 1. On the right side is sample 2. Okay, focus on the left side for just a moment. This is largely the web-based portion of Ad Health. Web data are far cheaper to collect than in-person data. So about 3/4 of Ad Health is collected now on the web. And then on the right side is in-person data collection, which is much more expensive, but there are certain measures that can only be collected well in person. So some of the cognitive measures and things like hearing. We're doing hearing tests in wave 6 of Ad Health. Things like grip strength can only be done in person. So each of the subsamples, sample 1 and sample 2, when weighted, will be nationally representative of Ad Health as well. So people can analyze either sample 1 or sample 2 or both. So the survey is common across both subsamples, but some of the measures in sample 2 are in person only and will be analyzed within that particular subsample. So all told, we're trying to collect 13,000 surveys, either by web or in person. One last thing on this slide, you might note on the left side, the web-based data, is that we also have something called non-response follow-up. So when we're doing the web survey right now, which we're almost done with, we're not quite happy. We knew we wouldn't be, because the people who are most likely to answer the web survey are people who have access to internet. Highly educated people like you and I are most likely to answer the web survey. So we're doing non-response follow-up. We're actually knocking on doors to collect surveys for the non-respondents in sample 1, so as to best fill out sample 1 to make it as representative as possible. Okay, after people, or when people are filling out the survey, whether it be by web or in person, we also ask them if we can come to their homes to do a home exam on folks. Most people say yes, some people say no in terms of consents. And so for each of the web survey, the non-response follow-up, and the in-person, we collect consents for the home exam. And then if we collect the consent, we try to schedule an appointment, and we try to go and visit them to collect things like blood pressure, take a blood sample, collect medications, and so forth. Okay, and then finally, we're also, again, rounding out wave 6 with a lot of contextual data collection. In terms of some of the measures that we're focusing on, it's structural racism, structural sexism, heterosexism, xenophobia, measures at local levels, county levels, state levels, and so forth. If Jennifer Montez was here, unfortunately her flight, she wasn't able to make it. She talked some about the kinds of state level measures that will be so important in understanding health and health disparities in the United States. We're also collecting a lot of environmental data as well, because we know where people live, and we can attach to where they live things like pollutants and water quality and lead, noise, and so forth. And then finally, we're adding administrative data on college transcripts, birth records, and mortality surveillance, the goal of which is to fill in the life course, try to understand health at time of birth, in adolescence, in young adulthood, middle adulthood, and all the way through death. Hopefully we'll be able to follow this cohort until they're in old age. So in sum, our Wave 6 plan is to collect survey data, either web or in person, from the AdHealth cohort members, to collect in-depth cognitive data on cohort members, both web and in person. I'll talk about that in a minute. Revisit them for an in-home health exam, to conduct key blood-based assays. So the blood gets shipped to our lab, and we conduct, I think, 24 assays for things like blood sugar and liver functioning and so forth. We archive the blood, and we archive microbiome samples that we're collecting so that future researchers can apply to use those archive samples for use. We're conducting mortality surveillance. We've had over nearly 700 deaths so far in the sample. We're building contextual data files, and then we're cleaning, documenting, disseminating, promoting, and providing support for Wave 6 data for the scientific community. Again, this is for you all. The data that we're doing this is to get the best data we can out to the scientific community to write better papers than someone like me could ever write. Okay, in terms of Wave 6 data collection to date, how are we doing? Again, the slide here, our total eligibility sample, instead of 20,700, we're eligible about 19,300. We've had about 700 die so far. Some others have said, please don't come ask me for any more of our time or my blood or whatever. And so we're 19,000, almost 400 are eligible, and we're trying to get 13,000. So how are we doing? Let's take a look at sample 1 right now. Sample 1, to refresh your memory, this is the web-based portion of AdHealth. Our goal here is to collect about 10,000 surveys on the web or through non-response follow-up. Okay, to date, just in terms of the web itself, not for non-response follow-up, we're about 1,000 away from our goal. So we're at about a 52% response rate. I get a report every single day from the field. How are we doing? How many surveys did we get last night? What did the quality look like, and so forth? And our goal is to collect 58% response rate with the web. In Wave 5, we did 53% on the web. So our goals are really ambitious this time. So how are we going to get from 52 to 58? A lot of people start the survey and break off. And many of them have given us permission to text them. So we're texting them, say, hey, could you please finish up? So that's one of the things we're constantly doing. We also got 3 more email and 3 more mail reminders that will be sent out throughout 2024 to try to finish this up. And we have a boost incentive, an extra $25 for those who have not yet responded. It's kind of like students, like rewarding bad behavior, giving them a good grade for the late papers. But that's what we're doing to try to get our sample, get our response rate as high as possible. Okay, our response rates on the web, females, higher response rates than males. Our highest response rates are among white participants in comparison to minoritized groups. And our highest response rates on the web are for those with a bachelor's degree or higher compared to those who are less than high school. So this is from the web, and so you see all these disparities, and we want nationally representative data. We want data where we can look at health disparities. And for that, you need, for example, low-educated respondents. So we're turning to NERFU. So again, we're out in the field all over the nation right now, actually knocking on doors to try to collect data from those who have not responded yet to the web survey. So how are we doing with NERFU? Again, we want to collect about 1,200 NERFU surveys. Our goals here are to increase the response rate in sample 1, to reduce the bias in sample 1 estimates, and then to improve diversity by race, by education, and males. Again, all of those who had lower response rates so far in the web survey. We started this in-person field work about a month ago. So it's really exciting. We've hired 57 field interviewers so far who are all over the country, again, knocking on doors, trying to collect data from these non-respondents. This is really hard work. Okay, so more specifically, trying to design this NERFU, this non-response follow-up, we've got about 7,000 non-respondents. We can't go after all of them. So what we did is we sampled the non-respondents, about 3,500 of them, in order to collect 1,200 completes. We've got a reserve set aside. But if you think about it, who we really want in NERFU, we want the low-educated non-respondents, and we want Black, Hispanic, and Asian sample members because they had lower response rates in the web survey so far. So we're primarily spending our NERFU time and money trying to increase the response rates using the in-person data collection for those who have lower response rates today. Okay, shifting to sample 2. This is all in-person portion of data of EdHealth. So it's the same survey that we're collecting in sample 1, plus a battery of cognitive, sensory, and physical functioning tests. So we're collecting cognitive data on the web at sample 1, but beyond that in sample 2, we're also in the homes asking people to play these cognitive games, these memory games, and to name as many animals as you can name in 60 seconds, and things like that. Things like HRS and other studies have done. Sample 2 is nationally representative, but with substantial oversamples of Asian, Black, and Hispanic sample members. So roughly we want to get equal numbers of those groups in sample 2 in order to make to be powered well enough to make comparisons across racial and ethnic groups. Our goal here is to collect nearly 3,000 in-person surveys. This field work as well started a month ago. We did do a pilot sample too last year for a couple months that was collected in 2 sites around the nation to see if we could do this. And so I'll show you a little bit of how we did there. We selected 2 sites with 8 field interviewers. We identified 262 sample members in those 2 sites. We implemented our whole battery, our training, our field work, our data processing and delivery, our QC, and we did this field work in 75 days in comparison to the 11 months of field work that we're doing right now. We completed 145 of those cases in 75 days, about 55%. Nationwide, what we just started on last month, we want to get to 73%. So this told me here that we can get to 73% if we're doing 55% in 2.5 months. We had in-person, sample 2, we had the highest response rates among Hispanic and Black sample members. In comparison to the web, we had the highest among white sample members. Interestingly as well, we had pretty similar response rates across educational attainments and biological sex. So in-person data collection is far different than on the web in terms of response rates. And despite a very difficult protocol, 3 hours, okay, in the home, the quality of data appears to be quite good. Okay, response rates again for this pilot, about the same for females and males. Pretty good across the board in terms of race and ethnicity. And then educational attainment, not nearly the kinds of disparities that we saw on the web-based sample 1. So what were our challenges in sample 2? Training. We're going into the homes, literally our field interviewers are taking a suitcase in with them. We have laptops, we have iPads, we have Bose noise-canceling headphones. We've got lots of devices and so forth, so it's really expensive, and training interviewers was very difficult for this protocol. Average time to complete was 3 hours, and the data uploads, cleaning data was much more complex than anticipated. We're getting data on hearing and cognitive tests and so forth, and these data are very, it's not like typical survey data to process. So we learned a lot from that. We started now to collect the full sample 2 data nationwide, like I said last month. We made some changes. We learned from the pilot, we made some changes in full sample 2. We've got 5 days of training instead of 3. We fly all the field interviewers into North Carolina to train them in person intensively. We're hiring up to 100 of them to collect the data to cover most of the country. We've got 57 so far. We've got 2 more rounds of training in April and May. Some field interviewers will do travel trips because we don't have somebody to collect data, for example, in North Dakota. So we'll fly someone in, spend a couple weeks there to collect the data from sample members. And the field period will last almost a year. Started last month, and we'll be in the field in person for the next year. We did a couple things to reduce the time. We switched from a computer-assisted personal interview where the FI read the questions to a computer-assisted self-interview, so which goes quicker. That's saving us about 30 minutes of survey time. And then we also had to eliminate an olfactory test, a smell test, which is really fun. Is this cinnamon or banana or whatever? And so that took quite a bit of time. And we eliminated the vision test as well because we learned from the pilot that almost everybody with corrective lenses has pretty good vision at these ages. So there's very little variation. Okay, then once people take the survey, they consent or not to a home exam. Again, we're trying to collect 7,500 home exams during the course of Wave 6. So far, we've done, all told, with sample 1 and sample 2, we've got, as of March 15th, we've got 8,250 surveys collected. About 5,800 people consented yes to a home exam. Sure, come to our home and collect data. One of the things we did in Wave 6 as well, a lesson for field work, instead of asking at the end of the survey, can we come to your home for a home exam? Instead now we ask at the beginning. We say, can we come to your home? Consent rates are far higher at the beginning and at the end. If you ask after 3 hours of field work, they say, no, you can't come back. But if you ask at the beginning, many of them say yes. And then others say, hey, ask me later. So we've got about 1,400 people or so who didn't consent yes or no, said, ask me later. So we're on the phone, we're texting, we're emailing them, say, hey, would you like to consent now? And so forth. So far, we've collected about half of our home exams. And this is really hard to do, not only consent, but then to set the appointment to get in the homes to collect that data. So that's our exam completes. They're about 3748 so far. The kinds of data we're getting from the home exam, including in Wave 6, including the anthropometric data. Probably at the bottom is probably what's most interesting is we've got a whole range of assays we're conducting this time on neurocognitive risk. So risk for Alzheimer's disease and related dementias that can be detected in blood samples. And that's something new we've added in Wave 6, along with the standard set of assays that we're collecting. More specifically, in terms of so we collect the blood as part of the home exam, as well as blood pressure, medications, anthropometrics. We send the blood to our lab. They conduct these assays. So we're doing, these are the specific assays that we're collecting, including glucose, lipids, renal function. These we've done for several waves in the past. A lot of inflammation and immune functioning assays. Hepatic injury, that liver functioning is what we're collecting there. And then we've got a lot of neurocognition assays, and we're testing for COVID-19 antibodies as well. Okay, a little bit of data. I think I got about 8 minutes. Is that, yeah, okay. So a little bit of data. This is from the first 6,788 surveys, unweighted. These are just distributions, but kind of some fun data to look at. So far, our average age is 43, the range being 39 to 49, so we're in the mid-40s. First, before I show you any distributions, these are some of the measures that we've enhanced in Wave 6. We think about the life course. Okay, these folks are not adolescents anymore, so some of the key things that we've added are more measures on race, for example, not just self-reports of racial identification, but what race do people think you are, okay? And measures of self-reported skin tone. In the past, we've had interviewer-measured skin tone as well. So there'd be lots of measures of racial identity, more in Wave 6 than we've ever had before. Many additional measures in terms of discrimination. Think about people in their 40s. We talked about today. They're pulled and tugged in every direction. They got kids, they're taking care of older people, and so forth. So we're thinking about midlife, thinking about stresses in their lives, chronic stresses, anticipatory stresses, how much do you worry before you leave the home, so forth. Work-life balance issues, caregiving issues. This is the United States in 2024. We're asking about trust in institutions, about police contacts, and health behavior measures, mental health, and then lots of survey measures of cognitive, physical, and sensory functioning in addition to the physical measurements. Okay, so a little bit here. Self-reported health, this isn't an innovative measure by any stretch, but one of the things I wanted to show you here, this is your typical five-point measure of self-rated health, is that we got 17% of people, these are young people, who are saying that they're in fair or poor health, and another 40% saying good, which in the US context is not good, because we way overinflate our self-rated health. And so this is not a good sign for people's overall health. COVID-19, interestingly, people are self-reporting. About 60% have had COVID by the time of the survey. Our early returns on the biomarkers suggest 60%. Now, whether or not those line up with each other, we'll see when we do the crosstab. But so far, about 60%. Chronic pain, not just, my hurting from something yesterday, thank you. Chronic pain, 32%, about a third of the people in AdHealth reporting chronic pain. Caregiving, which is an interesting thing. Are you taking care of an aging parent? If you add up the very true or somewhat true, it's 12% of the sample. Most of these are female. So this, in addition to people's own children, 1/8 of the sample is caring for a parent nearly all the time. Sense of purpose, 5 minutes. So we've got about 60% of the people who say they have a true sense of purpose in life, but 40% who are not fully sure about that. So this is something we were urged to add to Wave 6 as well. Wanted to show you this one. We added a battery of trust. This is something that the GSS has done for a number of years. Trust in the scientific community. We've got trust, I think we've got 12 or 15 of these measures. Right now, 22% of the people are saying that they distrust the scientific community, and 30% of the people are saying, maybe. Mm-hmm. These are people who answered AdHealth. Okay? These are early adopters of AdHealth, and half of them saying that they kind of express either ho-hum or distrust in the scientific community. Mm-hmm. Opiate drug use, ever take more than what as far as 9% so far, again, among early respondents. Something that I added, a personal interest of gun ownership, 43% of people in AdHealth. Again, these are unweighted measures, having guns in the home. And then finally, I wanted to show you a little bit of data on the cognitive batteries. So we're collecting these measures both on the web and in person. We're using something called Test My Brain, which comes out of Harvard. A larger mind at Harvard has worked with us on this web-based data collection of cognitive functioning. We're doing 4 tests that our neurology consultants have worked with us to include. This includes measures of verbal memory, processing speed, executive functioning, and short-term memory. This is the one I'm going to show you on the end, this backward digit span. It asks you, or it shows you on the computer screen, number 2, 1, and you've got to type in 1, 2. Okay, and then it goes to 3 digits. 5, 3, 2. You put in 2, 3, 5. Okay, and so forth and so on. You see, how many of these strings can you get correct? The data suggests so far that people on average, on the far left, get about 5 of these correct. The AdHealth sample members so far are in the dark blue. The volunteer sample at the Test My Brain website is a little bit higher. That's called the normative sample. It's not nationally representative. So our AdHealth sample members are doing a little worse than the volunteers. We think the volunteers are people who log onto the website and say, oh, let's figure out how smart I am. So we're doing a little bit worse than the normative sample. But then our educational gradient suggests that something that we'd expect to see, that people with higher levels of education are remembering more of these backward spans more so than people with less education. So our cognitive measures so far on the web look quite good in comparison to normative data, in comparison to other data sets, and in relationship to educational attainment. Okay, access to data. Again, these data and AdHealth data going back for decades now are available through ICPSR at the University of Michigan. This is a smaller sample at ICPSR. It's great for students. It's free. You download it. You can start working with them as you sit at your seat here. But it's a smaller sample, and it doesn't have as rich of measures as the restricted use data. Restricted use data is through contract. We have a full-time staff member. All she does is contracts. Contracts last 3 years. You can apply for them and protect the data, sign a plan, and have access to the data. And I encourage faculty here to think about applying for a contract for their students and themselves. Visit our website in order to figure out how to get access to the data. We're there to help. So in terms of Wave 6 data, we're going to be disseminating data in 2025. It's not going to be January 1st. It'll probably be somewhere between September and December of 2025, survey data, the biological data, and so forth. It's going to be an amazing data. We're thinking again about life course, health, health behavior, cognition, and the social and economic factors that drive these health and health disparities. We also have a users conference coming up in a couple months at this beautiful conference center in Chapel Hill. We do this every other year, and a couple hundred people come to Chapel Hill to learn how to use the data and give paper presentations and so forth. Okay, so finally, I acknowledge generous funding from NIH, National Institute on Aging, NICHD, other co-funders as well, and all the people and all the effort that goes into producing this amazing data. So thank you for your attention. If you've got any questions, I'd be, please email me. I'm happy to answer any questions.